I want you to think about the friction of starting a new role.
Oh, yeah, that is universally painful.
Right. Or even just, shifting to a different department within your current organization.
Mm-hmm.
Think about those first few weeks. The agonizing delays in getting the right software licenses approved.
The endless barrage of repetitive HR forms.
Exactly. And those incredibly awkward conversations where you have to essentially justify your working style or specific needs to a brand new manager who knows absolutely nothing about how you operate best.
It's exhausting.
It is. It drains your executive function before you even have a chance to touch the actual work you were hired to do.
Yeah, you're burnt out by day 3.
Totally. Now take that entirely relatable everyday corporate frustration and multiply the stakes by about 1,000.
Right.
Imagine those administrative delays are happening in an environment where human lives are quite literally on the line.
And where the financial cost of that specific inefficiency is bleeding millions of pounds out of the system.
Millions.
Yeah.
I mean, anyone operating in public healthcare knows the sheer financial bleed of the agency staffing reliance. But today, we are taking a deep dive into an incredibly fascinating strategic framework.
The NWAF.
Yes, the National Workplace Adjustments Framework. And our mission today is to explore how something that sounds, at first glance, like a totally standard, mundane HR process, has actually evolved into this critical national-level workforce asset.
And an asset specifically designed to retain neurodiverse talent.
Right, which is huge.
It is a massive and frankly overdue shift in perspective. When we analyze the core mechanics of this framework, the theme that jumps out immediately is the aggressive transition away from a highly fragmented system.
Toward a more unified approach.
Exactly, toward a unified, standardized approach. Healthcare right now is navigating an intense dual pressure.
Yeah, the source material was very clear about that tension.
Right. On one hand, there is an urgent top-down mandate to drastically reduce reliance on expensive agency staffing.
Because it's bankrupting them.
Completely. On the other hand, there is a sudden realization that they absolutely must retain a neurodiverse workforce that is essential to modern clinical delivery.
And the numbers on that are higher than people think, right?
Oh, much higher. We were talking about a clinical environment where an estimated 1 in 20 staff members are navigating ADHD, autism, or other neurodivergent conditions.
1 in 20. That's a massive chunk of the workforce.
It really is. And historically, the way this was handled was a highly decentralized, trust-by-trust approach.
Meaning everyone was just sort of winging it locally?
Basically, yeah. Every single trust was essentially making up its own rules, its own procurement processes, its own timelines for basic workplace adjustments.
Which sounds like a logistical nightmare.
It was. And what this framework makes abundantly clear is that treating neurodiversity retention as an afterthought or, a localized administrative burden is no longer just inefficient.
It's structurally unsustainable.
Exactly.
Okay, let's unpack this.
Yeah.
Because the financial and operational impacts we're looking at here are staggering.
They really are.
When most people hear the phrase workplace adjustments, it's incredibly easy to file that away in your brain under, like, well-being or compliance.
Right, the warm and fuzzy stuff.
Yeah. But this approach explicitly ties these adjustments to cost improvement plans, to frontline patient safety, and to severe medico-legal risk.
Which completely changes the conversation in the boardroom.
It has to. I want to zero in on what is being called the burnout to agency pipeline, because the cost of turnover is just mind-blowing.
Let's hear the numbers.
We know that recruiting a single new nurse costs around £12,000 in purely administrative and onboarding costs.
Just to get them in the door.
Right? And if you have to replace a senior clinician, you are easily exceeding £50,000 before they even see a single patient.
Which is just a colossal waste of resources.
It really is.
If we connect this to the bigger picture, you start to see why those baseline recruitment numbers only tell a fraction of the story.
Else.
Well, it's not just about the one-off transactional cost of replacing a body. It's about the underlying root cause of why those highly trained, highly capable staff are walking out the door in the first place.
Right. The environmental friction.
Exactly. There is a very clear, very troubling trajectory outlined here. When frontline staff with ADHD or other neurodivergent profiles are left unsupported in high-friction administrative environments, they don't just magically push through it without consequences.
They mask it.
They mask it, they exhaust themselves, and they are significantly more likely to experience severe burnout.
And burnout isn't just feeling tired.
No, burnout inevitably leads to performance dips. which leads to extended sickness absence.
Which puts pressure on the rest of the team.
Completely. And the ultimate outcome of all this unsupported, localized friction is that they exit the permanent system entirely.
Right, but they don't stop being nurses, do they?
Uh-huh.
I mean, they don't just suddenly abandon a decade of clinical training.
Exactly. They exit into agency work, they become locums. And this is where the financial strain compounds to an absurd degree, because the trust still has the exact same number of patients to treat.
So they have to fill the gap.
Yes. So the trust then has to pay massive, extortionate agency premiums just to maintain basic, safe staffing levels.
Wait, so they are quite literally paying a premium to hire back the exact same clinicians they just lost.
Yes. Simply because the agency model offers the clinician more control over their environment and schedule. It is a catastrophic failure of retention disguised as a staffing shortage.
It's the ultimate vicious cycle. You grind your own experienced staff into the ground because you won't provide, what, a 100-pound piece of speech-to-text software?
Or a pair of noise-canceling headphones, yeah.
They quit over that, and then you pay an agency 3 times their hourly rate to bring them back on the Tuesday night to fill the hole they left.
It's madness.
It really is madness.
Yeah.
So how does NWAF actually disrupt this pipeline?
It disrupts it by entirely removing the bureaucratic friction that causes the burnout in the first place.
Oh, I see.
Endeva provides pre-validated, low-cost adjustments that can be deployed immediately.
Meaning no 6-month waiting lists for an occupational health assessment.
Exactly. No waiting months just to get those headphones. It intercepts the clinician before the burnout sickness absence begins.
That's proactive.
Highly proactive. And the return on investment here is almost difficult to comprehend because it is so highly leveraged.
Give us an idea of the ROI.
Preventing just 5 experienced staff members from leaving a trust each year saves over £100,000 in recruitment and agency costs alone.
Just 5 people.
5 people.
Yeah.
In a trust of 10,000 employees, saving just 5 neurodivergent staff members from that burnout to agency pipeline fundamentally alters the budget.
That is incredible. And there is a quote in the material that really anchors this entire paradigm shift.
I know exactly the one you mean.
It says, this is not a well-being initiative. This is financial stewardship.
That really is the crux of it all.
This is financial stewardship. That is such a razor-sharp way to reframe it. We aren't just talking about making people feel warm and fuzzy.
No, we're talking about stopping a multi-million-pound hemorrhage.
Exactly. But here's where it gets really interesting. Because the financial bleed doesn't just happen when people quit.
Right.
Let's talk about the absurdity of the status quo for the people who actually stay in the system, but who just move to a different ward.
Or get a promotion.
Or transition to a neighboring trust.
Yeah.
It's like moving to a new house.
Yeah.
But the movers refuse to bring your prescription glasses until you take another eye test.
That is the perfect analogy.
It's maddening. You're the exact same clinician, just on a different floor.
It is arguably one of the biggest hidden inefficiencies in the entire healthcare system.
Why does it happen?
Well, under the legacy model, when a clinician makes one of those internal moves, their support slate is essentially wiped clean.
Wow.
The new department doesn't recognize the old department's paperwork, so the clinician has to re-explain their neurodivergent needs to an entirely new set of managers.
Managers who might have 0 training in neurodiversity.
Precisely. They have to repeat occupational health assessments from scratch. They wait weeks, sometimes months, for vital equipment or software to be reapproved and reordered.
Which makes absolutely 0 sense, especially as we see the rollout of integrated care systems, or ICS.
Right.
The whole point of an ICS is regional collaboration, isn't it? It's about breaking down the walls between neighboring trusts so staff and resources can flow smoothly across a region to wherever the patient demand is highest.
That is the theory, yes.
So how can you possibly have an agile integrated system if a specialized nurse moving 10 miles down the road loses all their bespoke support software the second they cross an imaginary administrative border?
You can't. You just can't. It completely undermines the entire concept of an integrated care system.
It's totally counterproductive.
And if we look at what that creates on the ground, it is an operational nightmare. You have wasted HR hours processing completely redundant assessments.
Paying twice for the same admin work.
Exactly. You have specialized, expensive ergonomic equipment sitting abandoned and unused in the clinician's former department because there was no centralized mechanism to track or transfer it.
Just gathering dust.
Yep. And most critically, You have unnecessary, dangerous delays in safe deployment.
Because they can't do their job properly.
Right. During those 6 weeks where a clinician is waiting for their adjustments to be reapproved, they are operating at a fraction of their capacity. Not because they lack clinical skill, but because the bureaucratic system has essentially reset their infrastructure back to zero.
Which brings us to the core solution of the framework, the adjustment passport.
Yes, the passport.
NWS introduces this portable, nationally recognized governance instrument. It basically mandates that once an adjustment is approved for a staff member, it is recognized and honored across the entire NHS.
It's such a simple concept, but revolutionary in practice.
I want you to put yourself in the shoes of an ADHD professional for a second. Imagine the sheer psychological relief of knowing that if you rotate to a new hospital, or if you finally accept that hard-earned promotion, you are guaranteed to be day one ready.
That is huge for mental health.
It is. You don't have to spend your first month advocating for your basic right to function.
Yeah.
The equipment, the software, the agreed-upon working patterns, they simply follow you, the individual.
It is a brilliant structural solution to a localized problem.
And fits the bigger picture, too.
It aligns flawlessly with the broader NHS long-term workforce plan. That plan places a massive emphasis on workforce mobility, consistency, and system-wide efficiency.
Which you need to survive modern healthcare demands.
Right. If you want a highly mobile, agile workforce that can be deployed across an ICS where they are needed most, you absolutely cannot have a system that penalizes them with administrative friction every single time they step into a new building.
The passport concept removes the penalty for mobility. Okay, I get the cost savings from retention, and I certainly get the efficiency gains from stopping the endless duplication of paperwork.
Sure.
But I have to ask the obvious question here. If the ROI is this clear, and the passports solve this massive headache, why hasn't every large organization done this already? Is it just standard bureaucratic inertia?
This raises an important question, and it's essentially the million-pound question.
Is it just laziness?
Historically, the barrier hasn't just been laziness. It has been a paralyzing fear of getting the legal compliance wrong.
Oh, interesting.
The decentralized nature of these organizations means local managers are terrified of making a misstep regarding equality legislation.
Nobody wants to be the one who gets sued.
Right. But ironically, that paralysis creates the exact risk they are trying to avoid.
How so?
When a trust fails to provide reasonable adjustments in a timely manner, they aren't just facing an annoyed employee. They are facing severe legal jeopardy.
Right.
Employment tribunal claims related to the Equality Act 2010 are surging across all sectors, and healthcare is completely exposed here.
Right, the medical legal threat.
Yeah.
And the cost of failure there is astronomical, isn't it?
Beyond astronomical, for a public institution, the cost of a single lost tribunal case is devastating.
You're talking legal fees, right?
Extensive external legal fees, plus massive financial settlements for discrimination or constructive dismissal.
And the PR nightmare.
The reputational impact is massive, which destroys your ability to recruit future talent. It is a highly precarious position for any HR director to be in if their defense relies on fragmented, inconsistent processes handled by untrained line managers.
Yeah, if you have 200 different ways of doing something, you have 200 different ways to fail a legal audit.
That's exactly right.
And that's where NWAF steps in with what is called compliance by design.
Yes.
It replaces the localized guesswork of a random ward manager with a consistent national approach to reasonable adjustments.
Standardizing the defense.
Right. It generates a gold standard audit trail automatically. So if a trust is ever scrutinized or taken to a tribunal, they aren't scrambling to find old emails from 2021.
No messy paper trails.
Exactly. They have clear, defensible, standardized documentation that proves exactly when and how they met their legal obligations.
Precisely. It shifts the entire dynamic from reactive panic to proactive defense.
Which is a huge relief for leadership.
It protects the organization at a corporate level.
Right.
It directly supports HR directors who are losing sleep over this exact risk. And most importantly, it ensures that the actual duty of care to the employee is met consistently.
It takes the subjective variability out.
Completely. Whether your manager happens to, quote unquote, believe in ADHD or not is completely out of the equation.
Which is how it always should have been. I want to pivot slightly here, because while we've been talking heavily about risk mitigation, compliance, and stopping financial hemorrhages.
The heavy stuff.
Yeah, the heavy stuff. There is something profoundly optimistic in how this framework reframes neurodiversity itself.
I agree.
It completely rejects the old-school medical model that treats ADHD or autism purely as a liability to be managed or a deficit to be accommodated.
Right, that outdated view.
It explicitly positions neurodivergent traits as a high-value clinical asset, assuming they are supported properly.
And that assumption is key.
Right. Think about high-pressure environments, like a chaotic A&E resuscitation room. The specific traits associated with ADHD, like rapid pattern recognition, lateral problem-solving, and hyperfocus, are actual superpowers there.
Absolutely.
These are incredibly valuable traits when you are dealing with a crashing patient and a dozen conflicting data points.
What's fascinating here is the stark contrast between those inherent neurological strengths and the environmental friction that completely undermines them.
Yeah, talk about that friction.
Well, you just described a trauma scenario where hyperfocus and rapid problem-solving literally save lives. That clinician is phenomenal in the Resus Bay.
The ultimate clutch player.
Exactly. But what happens when the shift ends? Those exact same strengths are neutralized when that clinician is forced to navigate what the framework brilliantly terms avoidable executive function friction.
Give me a concrete example of that friction. What does that kryptonite actually look like on a ward?
It looks like forcing that brilliant trauma clinician to log their mandatory training hours in a clunky, archaic, 5-step digital portal that crashes constantly.
Oh, that would drive anyone crazy.
It looks like a chaotic, noisy nurse's station where they are expected to calculate complex medication dosages while 3 phones are ringing and alarms are going off.
Sensory overload.
Yes, it looks like deeply inconsistent communication protocols from management. That is the kryptonite. You have brilliantly capable clinicians who can handle massive clinical trauma, but they are being cognitively drained and broken by the administrative environment surrounding the clinical work.
Which is such a tragic waste of human capital.
It really is.
And to fix that, the NWAF framework identifies highly specific, targeted interventions. And what's amazing is that they are so unbelievably simple.
We aren't reinventing the wheel.
No. We aren't talking about million-pound technological overhauls or completely rebuilding hospitals. We are talking about incredibly practical adjustments.
Very low-hanging fruit.
Things like providing dual monitors, using digital checklists instead of verbal handovers, creating simplified task sequencing. And my personal favorite, establishing dedicated quiet zones specifically for medication preparation.
And we really need to look at why those specific interventions work and who they actually benefit.
Yeah, let's break that down.
Take the quiet zone for medication preparation. For a clinician with ADHD who struggles with sensory filtering, trying to calculate a high-risk dosage in a busy hallway is a recipe for cognitive overload and potential error.
Because their brain is trying to process every single alarm and conversation at once.
Right. A quiet zone removes the sensory friction, allowing their executive function to operate smoothly. But here is the critical systemic insight.
Yes, that.
Creating a quiet, distraction-free zone for preparing high-risk medications doesn't just help the neurodivergent nurse, it fundamentally improves patient safety across the board.
Because nobody should be distracted while mixing meds.
Exactly.
Yep.
It reduces the cognitive load for neurotypical staff as well.
It's the curb cut effect, but for healthcare administration.
Yes, exactly. The curb cut effect. When you implement clear, structured digital workflows, or when you stop relying on unstructured verbal handovers, you are upgrading the safety and efficiency of the entire team.
It lifts everyone up.
These adjustments support the specific individual, yes, but they ultimately strengthen the resilience of the wider clinical environment. It is a massive systemic upgrade that is cleverly disguised as an individual accommodation.
So what does this all mean?
It means big changes are coming.
When we zoom out and look at the macro picture, the bottom line for 2026 and beyond is crystal clear. As integrated care systems continue to mature, and as the demand for healthcare continues to outpace the supply of trained professionals, the reality is stark.
Very.
Maintaining 200 different localized approaches to workplace adjustments is completely unsustainable. It is logistically absurd and financially reckless.
The future vision outlined by this framework is built entirely on the foundation of national consistency.
It has to be.
NWAF offers a highly practical roadmap to reduce duplication, significantly improved staff retention, and a much lower reliance on those budget-draining agency premiums.
Which solves both of the dual pressures we talked about at the start.
Right. It provides stronger organizational governance, legal defensibility, and actual workforce mobility across those integrated care systems.
It's a win-win.
It allows a complex organization to stop playing defense where they are just trying not to get sued or trying not to lose their staff, and finally move toward proactive, strategic workforce efficiency.
I want to read that anchor quote one last time, because if there is a single takeaway from this entire deep dive, it is this exact paradigm shift.
Let's hear it.
This is not a well-being initiative. This is a strategic workforce efficiency tool.
It really hits home.
It's about retaining vital clinical talent, aggressively reducing corporate risk, and ensuring that the people who dedicate their lives to caring for patients actually have the systemic infrastructure to do so without burning out over a broken chair or a delayed software license.
It fundamentally changes how we value and support neurodiversity at scale.
Absolutely.
And it leaves us with something really important to consider, regardless of what sector you work in.
Think about your own daily work environment.
Right. If standardizing simple administrative workflows and creating portable adjustment passports can retain highly skilled neurodiverse talent and save millions of pounds in an environment as infinitely complex and high stakes as the National Health Service.
Yeah.
What hidden executive function friction is quietly draining top talent and massive budgets in your own industry right now, simply because no one has bothered to build a passport for your workplace.